today is her own Dr. Aishwarya's batchmate, Dr. Charanya Chandrasekhar. And to introduce her, I now call upon her own guide, Dr. Vijay Amritraj.
Thank you, ma'am. Okay. I'm happy to introduce the last session of the day from the bubbly team, Dr. C. Charanya. She had graduated from Satyabama Dental College and completed her post-graduation during the period of 2016 to 19 from her own college. And she's currently working as a senior lecturer in Rahu Dental College and Hospital. And she's a very good clinician and she's very passionate about teaching. And she has over 11 publications to her credit in indexed journals. And she's also a peer reviewer in indexed journals. And she's inclined towards more research, and her area of interest is bacteriology, resorption, and irrigation techniques. She had presented various papers in international and national conference and won best papers to her credit. Over to Charanya.
So thank you so much for the introduction. And it's an honor to get that introduction from my own guide. Thank you, sir. Thank you, ma'am, for this opportunity. I'll just share my screen. Ma'am, I hope I'm visible.
Yeah, the screen is visible. You can go ahead.
Yes. So hello and good afternoon to one and all. Before starting my presentation, I would like to extend my pranam to all the guides, all the staffs of team SRM who has guided and molded me completely, and for what I am today is purely dedicated to everyone. So today's topic is going to be structure-bound guide to access cavity preparation, especially for the molar root canal treatment. And this is going to be more of a clinical topic, and it's going to give you a confident and a hassle-free method to do an access cavity preparation, keeping in mind the scientific knowledge as well as the traditional part. So the main ideology behind this presentation is being completely dedicated to Dr. S. Balagopal sir, who has 29 plus years of his clinical and academic experience, jotted down or pointed all these methods in a very simplified manner, which gives us a confidence in doing an access cavity for molars without any errors. So we all know access cavity is the gateway to successful root canal treatment. So basically for an access cavity preparation, there are three phases which are important: the penetration phase, the enlarging phase, and the finishing and flaring phase. But on thorough review of literature, where to penetrate, how much to go about is a small lacunae which is present. So this lacunae has been completely eradicated by Dr. Balagopal sir. So since then, it has always been said from the past to the present that access is success. So for a successful endodontic treatment, there are basically three needs which has to be fulfilled. The first one stating the operator needs, the restorative needs, and also the teeth needs. All these three fulfills gives you a proper endodontic treatment. In case of a traditional access cavity, it is always directed towards the operator's need rather than primarily focusing on the restorative or tooth needs. So the traditional access cavity thereby sometimes results in loss of more tooth structure. So when there is an increase or a massive amount of loss of tooth structure, this eventually leads to gross weakening of the tooth structure. So basically, we all know that the pericircular dentin, that is 4 mm above the CJ and 6 mm below the CJ, is a most important landmark that should be preserved or conserved for the longevity of the tooth. Sometimes, ma'am?
Sorry.
Yes. So this has to be preserved for the longevity of the tooth. So in search of that, there's a constant evolution or constant quest to find out how to protect or how to maintain the longevity of the tooth. And thus, one such evolution was the modern endodontic access cavity, which was by Clark and Kadami, whose main attempt was directed towards dentine conservation. There are many other variations which are also seen in access cavity preparation. That is one, as we saw, by Clark and Kadami. The second, which is by the ninja axis, which is directed toward the central fossa, and the tress preparation, which is more orifice directed access cavity preparation. The major aim or the objective, the goal, is to minimize the tooth structure removal and to improve the mechanical stability. That is, it gives a long-term survival and the function of the tooth. That was the main objective for the evolution of the modern access cavity preparation. So what is the basic necessity? So why do we actually need to preserve the tooth? It is because no material or technique which we are going to follow is going to replace or can replace the mechanical characteristics of the tooth structure that is lost, especially in the stress-bearing areas. So we need to keep that in mind, that no restorative material is going to replace the tooth structure which is lost. So the treatment steps were directed towards conservation of the dentine, especially in the root-filled teeth. So as we saw, therefore, the final restoration, final quality of restoration is directly proportional to the tooth structure remaining after the access cavity preparation. So why particularly molars? Why are we concentrating more on molars? Is because the bite forces in the molars are considerably higher. So especially in the cuspal tips, the marginal and the cross ridges bear the high amount of compressive stresses. In order for the molars to maintain this compressive stresses, it is better to preserve as much as dentine and to preserve all these important landmarks so that the longevity of the tooth is increased. So you can see in this slide, there is evolution in just preservation of more and more dentine so that the longevity of the tooth is improved. Though there is an evolution, there are also drawbacks, which I'll be mentioning in my further slides. The current concept, that is, there is no stepwise guide for the penetration or to prepare for the access cavity preparation. There are only requirements or certain guidelines or general prerequisites which are given, such as you need to, the shape of the cavity will be quadrilateral or triangle, and the basic armamentarium that is required, the position in relation to CJ, the problems which you might encounter if access cavity preparation is wrongly prepared. What are the difficulties or most common difficulties that you might encounter during the preparation is that the presence of a crown or a restoration, or if the tooth is tilted, a small chamber or something. Or sometimes what will you do if you do a wrong access cavity preparation? That is, you might end up in perforation, then management of perforation and all this. And then there are guidelines stating that you need to follow the caries to gain the access. So this structure bound guide gives you a stepwise procedure of how to go about with an access cavity preparation. So before starting with it, we'll have a general prerequisites that we need to be noted before starting it. So the first one is going to be the visual examination. Anything before you start, you need to visually observe the morphology of the tooth, the cusp, the root position, the angulation of the tooth, and the coronal clefts. After visual examination is going to be a good X-ray or an IOPA which needs to be present. So this IOPA is going to give you a complete ideology of the number of roots, the root canal chamber, and the pulp space. Also the height or the width of the pulp chamber also. So apart from that, you need to examine the cemento-enamel junction. So this structure bound guide is going to follow few of the concepts which was previously given. First one being the law of centrality, that is, the orifices are located in the center of the canal in the CJ level, then the law of concentricity, and also the law of symmetry. So we are going to follow all these concepts here. Apart from that, there were studies done by Allen and Associates who have given us an outline picture of the length from the cusp tip to the roof of the pulp chamber. By doing various studies, they have given or they have formulated that in maxillary molar, it's almost about 6.24 plus or minus 0.88 millimeter length. And in mandibular molar, it is 6.36 millimeter plus or minus 0.93. So approximately a 7 mm space is present from the cusp tip to the roof of the pulp chamber. So this gives us another picture to have a confident access cavity preparation. So let's get started with the structure bound guide to access cavity preparation in both mandibular molars and maxillary molars. So the first and the foremost, what we are going to do is map the landmarks on the occlusal surface by keeping a definitive landmarks on the occlusal surface. For the mandibular molars, the first point is going to be on the cuspal eminence of the mesiobuccal cusp. The second point is going to be 1 mm buccal. It's going to be 1 mm buccal and 1 mm distal from the mesiolingual cuspal eminence. And the third point is going to be 2 mm buccal and 1 mm lingual towards the central groove. And this point should be 1 mm mesial to the transverse ridge, distal transverse ridge. So these points have to be joined to form an outline. So it will either form a laminar form or will give you a tubular structure. Similarly, for the maxillary molars, the first point is going to be on the mesiobuccal cuspal eminence. The second point, the palatal aspect, is going to be 1 mm buccal towards the buccal and 1 mm distal to the mesiopalatal cuspal eminence. And the third point, the distal, is going to be on the 1 mm mesial to the height of oblique ridge. It's going to fall 1 mm mesial to the height of the oblique ridge. On joining all these, in case of a rhomboidal tooth structure, we'll actually get a equilateral triangular form of an outline. Whereas when the mesiodistal width, when the buccopalatal width of the molar is little higher, the base of the triangle will fall on the mesial aspect. Whereas in the buccopalatal width is markedly longer, we'll actually get an ovoid or a scalene triangle form of an outline. So we need to remember all these markings to go about with that axis cavity preparation. So the second stage is going to be, we are going to use two scientific evidences that we previously saw. One is by Allen and Associates, who stated that there's about 7 millimeter thickness of the roof of the pulp chamber. And second, we are going to follow the law of centrality. So after that, we are going to start with the first level of penetration. After the landmark confirmation, we either take a Fisher burr or we take an SF41 and drill to about 2 millimeter in the specific landmarks. Once that is done, we need to flatten the floor. The second stage is going to be the second level of preparation, wherein the burr is going to be oriented towards the center. We are going to follow the law of centrality here. So when the burr is oriented towards the center, we have to go to a depth of about 3 millimeter. So 2 plus 3, it's going to be 5 millimeters so far. So after 3 millimeters, we are again going to flatten the floor. And the last step is going to be the penetration of the roof, wherein after the 3 mm, we are going to create depth cuts of 2 millimeter. By this time, you would reach the roof. So the first level, which is going to be 2 millimeter, the second stage, which is going to be 3 millimeter, and the third stage, which is again going to be 2 millimeter of depth cuts. So let's see step by step. First, we have marked the landmarks. And then after that, 2 millimeter of depth cut is prepared using an SF41 burr. After flattening the dots, after joining the dots and flattening the surface, we orient the SF41 burr towards the center and create a depth cut again for 3 millimeter. After creating it, again, we need to flatten the floor like here. And then we have to drill for 2 millimeter, which is going to be the third stage of penetration. Here you can appreciate that we have almost penetrated the roof of the pulp chamber. So once that is done, we need to completely de-roof the pulp chamber. And by here, we also gain a straight line axis. So it is just completely de-roofing the pulp chamber in just 3 easier steps. So this is again a pictorial representation of the same in mandibular molar, wherein 3 points are marked. The landmarks are then connected. We go about 2 millimeter, then 3 millimeter, and again a 2 millimeter depth cut. And there you go. You have opened the pulp chamber. Similarly, a pictorial representation of the same, wherein you join the dots, 2 millimeter, 3 millimeter oriented towards the center, and again 2 millimeter oriented towards the center. There you go, you get the complete opening of the pulp chamber. So what is the basic advantage of this axis cavity preparation is that it has a definite outline. It gives you a definite cavity outline of how the coronal, based on the coronal landmarks. And also there's going to be a precise de-roofing of the pulp chamber. There is no pulp chamber which is present, which might cause an interference in removal of the necrotic pulp. Also, it uses strong scientific foundations, also along with the integration of the tooth morphology and endodontic odontometrics. It also prevents inadvertent gorging in the dentine. Thereby, you preserve the dentine and also improve the longevity of the tooth. And it is also a precise guide for an access cavity preparation. So as I previously told you, the modern access cavity, though has its own advantages, there is also disadvantages which has been stated by Neelakantan P. et al., who stated that when there is orifice-directed approaches, it shows relatively inferior results in debriding of the pulp chamber compared to that of traditional access cavity. Also, in a study done by Rover et al., who stated that the modern endodontic access cavities did not show a great influence on instrumentation efficacy and fracture resistance, also when compared to that of traditional endodontic cavity. Also, Shielder gave a statement stating that when he tried to create an access cavity of 4 mm to 5 mm, he had a difficulty in getting an acuity of the instrumentation which he's been using. And he stated that it is not actually good. So this program, that is this structure bound guide, not only gives you a modern solution, that is it is conserving the dentine. At the same time, it is completely de-roofing the pulp chamber and giving you a straight line access, which is must. So keeping my session very crisp, I would like to just give a small take home message that I would like everyone to attempt the structure bound guide access cavity. It's going to be a perfect guidance in just 3 steps. That is, it's just going to be a 2 mm depth cut followed by 3 and again a 2 mm, and there you go, you get a complete access to the pulp chamber. And also it completely de-roofs the pulp chamber. Then, in cases of modern access cavity, something which we might require is the presence of microscope. Whereas in this structure bound guide, just with the presence of a definitive landmark and proper orientation of the burr, you're comfortably able to gain access to the pulp chamber. Not only that, you're going to have a straight line access to the instrumentation and thereby preventing more of instrument fractures and everything. So these are my references. And this is my team when I did my post-graduation in SRM Dental College. And I sincerely extend my thanks to all the staffs and HOD ma'am for giving me this opportunity. And it's an immense pleasure to present in front of the staffs again. Thank you, ma'am. Thank you everyone for the patient listening.
Thank you so much, Charanya.
Thank you, ma'am.
I now call upon Dr. Rajkumar to do the honors.
Thank you, ma'am. Thank you, Charanya.
Thank you.
Charanya, it's indeed a very proud moment. We are like parents now, you know,
Yes,
watching our children excelling so well in our field. I feel same with Dr. Balagopal sir also. He also must be feeling the same way. I just wanted to just add on few things related to this. Though we speak about all this modern access cavity preparation by Academy, Ninja, there are few dark areas related to irrigation and what the steps what you have given us today will really help our PGs to to do a better access cavity preparation, so that they don't end up in doing some overzealous preparation.
Yes, yes. Following this has actually helped us to conserve the tooth and also prevented inadvertent gorging in the sides of the walls, searching for the canals and all that.
So thank you very much. I really cherish our days as you people, as our postgraduates, and in fact our trip to Korea for IFIA conference. Charanya used to listen to my presentation. I used to listen to Charanya's presentation. It was really a wonderful experience along with map, shopping and things like that. Now, Kritika, Dr. Kritika, do you have any questions?
Yes, sir. Yes, sir.
Yeah, please.
what is the basis of 2 mm, 3 mm, and then penetration? What about attreated teeth?
In case of an untreated teeth, basically we need to find out the CEJ level. So the general prerequisites we need to follow with the CEJ. After that, we need to analyze and then go about with the height of the tooth. So this 2 mm, 3 mm, and 2 mm is generally given from the outline. That is based on the Allen and Associates and all the other studies. It has been formulated in the way of 2, 3, and again 2 mm. But in case of an untreated teeth, you basically have to find out the height of the tooth structure and then go about. See, any tooth will have from the cuspal tip to the roof of the pulp chamber will be of 7 millimeter. So you need to keep that in mind and orient your burr accordingly so that you don't penetrate. I mean, you don't do any perforation. So that is the basic concept here. So keeping the ideology of 7 millimeter in mind, we have formulated such way. So in a treated tooth, again, you have to examine the CEJ and then go about with your penetration.
So can you tell us what about in the case of a calcified tooth? Does the same principle follow?
In case of calcified tooth, also the same principle follows. The only thing is the calcification part of the pulp chamber has to be trucked and removed. Otherwise, the preparation aspect is the same.
So should a routine minimal area exposure with the CBCT taken pre-operatively become always a norm? Is it a must?
No, ma'am. Generally, with just a normal IOPA, we'll be able to guide along. I mean, we'll be able to give an outlook of how to proceed with the root canal treatment. So this structure-bound guide does not advocate mainly on CBCT, but just with the mere IOPA, you can able to locate the height of the pulp chamber. You'll be able to analyze the number of roots, the thickness of the chamber, and then go about. So the presence of CBCT is not a must in this case.
Okay. How about guided access in case of a clinical scenario where the guide points will be missing due to cavitation?
Generally, for in such cases, there's some concept known as endodontic pre-buildup. So when you do that, ultimately you're going to get half of the tooth structure which is being lost because of the caries. Then again, follow the same norms as structure-bound guide has been given, and then there you go with the access.
Thank you, Charanya. Thank you
Thank
for
you so much, ma'am. I hope I did some justice.
Yeah, you did. You did. It was a very crisp and a very confident presentation. Very nice, Charanya. You did a very good job.
Thank you, ma'am.
Couldn't stop appreciating you.
Thank you, ma'am. Thank you for the guidance, ma'am.
Ma'am, kindly do the honors of presenting the certificate. The doctor.
Thank you so much, sir. Thank you, ma'am. Thank you for giving me this opportunity. It's indeed a pleasure, ma'am. Thank you. Thank you.
So that concludes today's presentations. I once again thank Vandana, Aishwarya, and Charanya for their wonderful presentation. And we have not been, we can say proudly that we have not made a mistake by, inviting you all to do the honors. Especially all three have, nobody was the same, and nobody was the same in way of presentation also. The topic that they have selected, everybody were so beautifully doing it. In fact, we got so many appreciations in all the groups that, the CAD group, the Endo Women Power group. Everybody have been appreciative of the way they presented, and also the way they have given, topic has been covered. So that is more important. And I'm sure that this will be just this beginning. We will be having many more such wonderful webinar series by our alumni, and we all are proud. We can see all our staff members are beaming with pride on having listened to our own students presenting. So thank you so much to all of you. And we will now be, waiting for the date of 29th, where we will have a second webinar series. Thank you one and all, and a very good day to you all. Thank you.
Thank you so much.
Thank you, ma'am.
I think we end the session this today.
Dr. Kritika, do you have anything to say regarding
Sir?
regarding certificate?
Yeah, that has been put in the chat box for everyone to
register. Yes.
will be those participation certificates will be given on 29th.
Yes. Yes.
Thank you.
Bye, Aishwarya, Charanya.
Bye, ma'am. Thank you, ma'am.
Looks like
Bye.
I'm